Our next topic is also very interesting. Ladies and gentlemen, MAFLD is no more a silent condition. It is now one of the leading causes of chronic liver disease and hepatocellular carcinoma. To talk more about its complications, I would like to invite our next presenter, Professor Waseem Jafri. Professor Waseem Jafri is a physician par excellence, teacher of the teachers, gastroenterologist. He is currently working as Professor of Medicine and Gastroenterology at Aga Khan University, Karachi. Please welcome Professor Waseem Jafri.
Finally, we are done. Thank you. It's a great academic conference and lots of things you have already heard about various aspects of life. But the most important thing that we should never ever forget is that, in order to improve ourselves, we have to be, thinking about all these things most of the time. All right, we have passed through a deadly pandemic called COVID. And everybody got very, very sensitive about it because your household, your neighbors, one of the relatives or whosoever, something could have happened. But here is a global non-infectious pandemic which is affecting, so we all know that it used to be called MAFLD, but that has been changed now to MAFLD and MESLD and all that bit. And non-alcoholic fatty liver disease to metabolic dysfunction-associated fatty liver disease in an attempt to improve the understanding and overall outcome of the disease. The leaping prevalence and formidable mortality rate of fatty liver disease throughout the world is quite worrisome. Due to the lack of appropriate knowledge of the natural history of the disease, suitable pharmacotherapy could never be devised. Thus, the management solely relies on patients' earnest cooperation with fierce lifestyle modifications changes such as exercise, weight loss, and dietary modifications. In an era when we are here, it is essential to come up with strategies to curtail the underlying risk factors in order to prevent the rapid progression of MAFLD in this review, which you would have access easily. The European Journal of Medical and Health Sciences will go through all the details. So when you talk about the regional prevalence of NAFLD or MAFLD, in the Middle East, as far as it is currently assessed, it's almost like 32%. South Africa, 31%. The pediatric, 1 out of 8. BMI, equal or more than 85 percentile for age and sex. This is important. Fasting sugars, one could see that. And the blood pressure measurement, again, the age group is less than 13 here. And plasma triglycerides, once again, and plasma HDL cholesterol. This is an upcoming problem that the pediatric population, which we all love so much for every aspect that they do, in fact. And at the same time, we love them. We must look into all these things that they are immune and not suffering from any of these things which is prevalent. Metabolic dysfunction-associated liver disease and metabolic dysfunction-associated steatohepatitis. Very important indeed. We should know that there is increased alcohol intake is also universally common, and in a country which we all live, this is not something that this is rare. You have to take the relevant history from the patient, and his background tells you he or she are they aware of it or not, because to ask something, and it is important for us to know it, because alcohol is not something that is not prevalent unfortunately, even in Pakistan. So alcohol-associated liver disease. So if one of us has got a fatty liver disease or MAFLD, we must always look for, something else as well, which could be more specific because there is no immunity. You can still have hepatitis B, C, and D in this subgroup as well, and that pertails and at the same time produces more catastrophic and earlier results as a result of that. So those things have to be looked at. Drug-induced liver injury. All right? So all of you are very familiar with it. So look at a prescription. So the prescription, as soon as the patient is speaking something to a general physician, the medicine is already on the writing. Another thing that he says, कि इधर भी दर्द हो गया, इधर भी दर्द हो गया, another medicine comes in. And यहाँ पे भी उसका हाथ लगा, एक तीसरी medicine. एक prescription के ऊपर आप 10-10 दवाइयाँ देखते हैं लिखे हुए. You know that, right? Wrong? Never seen it? ठीक है. And so drugs interactions is very, very important, not for liver, for all aspects of our body. And as a result of that, in fact, patients suffer hugely. Very sad story. And then again, we have already spelled out the monogenic diseases due to viral hepatitis, autoimmune hepatitis, and all those things. So we must be very familiar with it. So that's how the MAFLD, or so-called MAFLD, but now it is more MAFLD because, why? Because metabolic associated steatotic liver disease, and that's how he explains it scientifically. And when this steatotic liver disease produces more ALT and ASTs going up and more hepatitic things, you call it MASH. We call MASH other things as well, right? And then it goes on to develop cirrhosis. The sad story is that when the patient enters your room and he or she has got relatives sitting behind, in fact 3 or 4 of them, and you see that they are also more moribund because what this patient has already developed, they are in that process that they are developing. So please take this notice and you will be doing an extraordinary service for humanity. Say, have you had your FibroScan, ALTs, ASTs, and all those tests done or not? Because it's not written here that you have it or not. And you will, fortunately pick up the disease at an earlier stage when reversibility is possible and hopefully done. Genetic versus role of metabolic comorbidities. And we know that diabetes mellitus is type 2 especially. In fact, these patients are very, very moribund with MAFLD disease and cardiac diseases and neurological ailments and all that bit. Obesity, very common. Everybody knows it, and no metabolic risk factors. All right, dietary and environmental contributors, yes or no? All right. Fat supply exceeds adipose storage capacity and genetic contributors. The genes that our parents have given us, we are extremely blessed with those things. And why should we blame the genes? It gets modified due to factors in the environment and others and our own doings. The pathogenic relationship between diabetes and MASH, the adipose tissue insulin resistance, increased lipolysis with free fatty acids, lipotoxicity, and reduction of anti-inflammatory adipokine secretion, reduction of adiponectin, IL-1, insulin resistance in liver and muscle, activation of pro-inflammatory pathways, and impaired insulin secretion, increased secretion of pro-inflammatory cytokines, MCP1, TNF-alpha-1, TGF-beta, and IL-6 and leptin. Role of GLP-1 in MASH pathogenesis, very important, increased. And we know that the pharmacotherapy that is being developed is looking into this GLP-1 status, and it is helpful. In the heart, the GLP-1 induces increased cardiac contractility, increased heart rate, myocardial injuries secondary to ischemia. Liver, glucose production. Muscle, glucose uptake and glucose storage. Insulin sensitivity. Pancreas, insulin secretion is increased, reduction of glucagon secretion, insulin biosynthesis, new beta cell formation, and reduction of beta cell apoptosis. And that's why the agonist medicines that are the hallmark of the treatment is so helpful. We all know that these patients, when they approach to you, or otherwise as well, in your neighborhood, in your relatives, in your own homes, in fact, the patient do not have presenting symptoms. And fatigue frequently is present because of obesity, right upper quadrant discomfort, incidental abnormal LFTs, incidental bright liver on imaging, and incidental hepatomegaly. Common scenarios are statin monitoring, annual reviews in type 2 diabetes, lipid and hypertension clinics, and medical insurance and occupational health checks. The evidence of mast-cell liver fibrosis, a risk of adverse outcomes. Look at that. As the fibrosis stage goes on the higher side from F0 to F4, we are reaching towards risk of severe liver disease, cirrhosis, and then all the aftermaths of cirrhosis. Liver-related mortality also climbs as the fibrosis goes from F0 to F4. The evidence of regression of MASH cirrhosis associated with improved clinical outcomes, and this is also listed here nicely. The pooled analysis of 1,135 patients with MASH cirrhosis from STELLAR-4 and simtuzumab studies have suggested improvement in MASH fibrosis stage associated with lower risk of liver-related events as the fibrosis gets less. Now, identifying advanced hepatic fibrosis. Already I have spelled that. In fact, as I said, patients sitting behind, the relatives or friends coming with your patient, sitting behind the patient, you have to identify them before, a poor outcome is there and hardly anything I would be able to do in order to produce reversibility. Case finding and high-risk population, strong. Clinical predictors of MASH and fibrosis, age, as we increase, equal or more than 50, type 2 diabetes, and first-degree relative with MASLD and cirrhosis. Other risk factors, sedentary lifestyle, Western diet, high fructose consumption, overweight and obesity, metabolic syndrome equal to or more than 3 features, other studies as well, and dyslipidemias and PCOS is also common, and endocrinopathies. We have several guidelines, and in fact, lots of things are already there, and little modification does happen. In type 2 diabetes, suspect MASLD and MASH and determine person's risk of advanced fibrosis. This is from the American Association for the Study of Liver Disease, having worked with them and the special interest group, which are the SIG groups. Increasing number of metabolic diseases, increasing risk of progressive liver disease. From the European Association of Liver Disease, Society for Liver Disease, MASH and advanced fibrosis screening is recommended in persons at high risk, age 50 or more, years, type 2 diabetes and metabolic syndrome. The American Diabetic Association also recommends screening is recommended. Diagnosis and screening. You already know that the liver biopsy for the MASLD and MAFLD thing, it's an imperfect gold standard. Invasive, painful, expensive, morbidity, mortality has been reported, sampling variability, observer variability, expertise to perform, and impractical for population screening. You don't do that as a population screening. Correct? Don't do that. Liver biopsy for screening purposes. All right. Chalo. Commonly used non-invasive tests are the hallmarks. We must have used them. All of you use them as well. The FIB4 is available on your cell phones with calculator studies. The MESL fibrosis score, the AFRI score, the NIS4 score, and FibroSure, HAP score, enhanced liver fibrosis test, etc. But the imaging is most important, and especially the first one, which is transient elastography, the FibroScan. The 2D shear wave elastography is there, and magnetic resonance elastography is also available for evaluation. So this is the fibrosis score, FIB4, based on age, platelet count, AST, ALT, and plus minus other lab values. Open your cell phones and calculator, and that's it. The vibration-controlled transient elastography for MASH fibrosis is the hallmark. This is very good. Most reliable in ruling out advanced hepatic fibrosis. Fibrosis unlikely or low value if it's less than 7 kilopascals. Higher values increases likelihood of more severe fibrosis, predict risk of decompensation and complications. Overestimation of fibrosis can occur, however, in cases of hepatitis, cholestasis, liver congestion, obesity, and if mast lesions are present in liver. Correlates well with portal pressure, 20 kilopascals. Common imaging tests for hepatic fibrosis. You know that already. I don't think I've added anything new here, but FibroScan is the most important diagnostic tool. And as soon as you do that, you have two relevant figures, the fibrosis score on the right hand, and on the left hand, you have the decibels per meter square, which is the liver fat score. And as it goes more than 220, it goes into very, very poor, and then 250 and 280 and 300 and 400 and all that thing. So it keeps on rising. So this is it. That is for the decibels per meter square for the liver fat score. But for the fibrosis score, we know 7 is our limit. As we cross that, we are going into, in fact, different F brackets from F1 to F4 or whatever. These imaging tests, liver stiffness, which is indirect measure of hepatic fibrosis and not hepatic fat content, except FibroScan and MRE. Screening for MAFLD and MASH is very, very important, and I've already spoken on this thing because that is most relevant to me, that screening is the best tool. If I know this patient in the earlier stage, F0 stage, I have done something very good for humanity, and as a result of that, in this patient, inshallah, would be saved from this problem because I can bring the fat score down with relevant treatment. So screening is important, and we have got primary care physicians, the internists, the general physicians, in fact, should be highlighted about all these facts. And I wish this hall would have been full of those, but unfortunately 2/3 of the seats are missing, which is not good. Because as we spread this news to the general physicians, come on, this is your responsibility. You see more than 100 patients a day. I see less than 20 patients a day. How can I accommodate all those patients? You can do a marvelous thing by preventing something rather than to cross those limits. Yes or no? जो हो रहा है ठीक हो रहा है ना, ऐसे करने दें. क्या ज़रूरत है किसी को तंग करने की? वो 20 में मुंह से लफ्ज़ निकल रहा है, उनके भेड़ रहे हैं. उनका टाइम ज़ाया होगा बेचारों का. हाँ भाई, गलती हो गई. You know that evolving treatment, resolution of MASH and reversal of hepatic fibrosis, standard clinical trials outcome, resolution of MASH with no worsening of fibrosis, improvement in fibrosis, stage 1 or more than 1 with no worsening of MASH. Patient targeted for pharmacotherapy, MASH with stage 2 fibrosis. Early intervention is the key. Treat each comorbidity is important. This is important. Obesity, which is important, and GLP-1 receptor agonist, you know that. Diabetes, pioglitazone, dyslipidemias, hypertension, and sleep apnea. Treat each comorbidity. Obesity, weight loss, exercise, and diet. And these are all patient-centered approaches. Cofactor, dietary modifiers, alcohol, smoking, fructose, and coffee. Look at the last one, which is the hallmark. More than 8,200 daily steps. Protection from incidental diseases, obesity, sleep apnea, gastrointestinal reflux disease, and major depressive problems, diabetes and hypertension. So exercise alone reduces liver fat, aerobic, 150 to 250 minutes per week. Resistance training, 45 minutes per day into 3 days per week. Avoid fructose sweetened beverages and added sugars. Weight loss, thresholds and impact on MAFLD. When a patient comes to me with fibrosis score on the high side or whatever, my first, in fact, dietary treatment is that when I repeat your fibroscan in the next 6 months to a year, I need at least, I would repeat it with 10% weight loss. So if his weight or her weight is 100 kilograms, it should become 10% would be 90. And then this is how you would see the results listed here. Steatosis goes down by 35 to 100%, weight loss more than 3%. Ballooning and inflammation, weight loss more than 5%, MASH resolution, weight loss more than 7%, and fibrosis more than 10%. Bariatric surgery is also one of those things that is a global, management thing, and patients have benefited, but they have their own sequelae. Surgery is alteration of human anatomy, and as a result of that, it's not that it is free of complications. So sleeve gastrectomy has given these good results with, MASH resolution, and the same for fibrosis, if that is what you are aiming for. And histological improvement in MASH, before it was MASH, and when it was more MAFLD and all that, vitamin E was prescribed quite a bit. And you would always see that prescription from a general practitioner, placebos, and pioglitazone. PPAR agonist, pioglitazone, is one of the best in these things, and you see that all arrows are towards the upside. So vitamin E, possible all-cause mortality, more than 800 international units per day. Increased hemorrhagic stroke risk, also shows reduced ischemic stroke risk, increased prostate CA risk, and use of these agents should be personalized for selected patients with histologically confirmed MASH after careful consideration of risk and benefit ratio. Pioglitazone, if you continue with it off-label, edema, weight gain, risk of osteoporosis, and equivocal in some of the studies, in fact, bladder cancer, and not in all. Here comes the GLP-1 receptor agonist, semaglutide, and this is very important to highlight because conferences globally are being benefited by these companies for sponsorships. So semaglutide is working at all levels from the brain to the liver and to the gut, and that's how the benefit comes into it for weight loss and diabetes and MAFLD. Resolution of MASH with no worsening of liver fibrosis, and the dose is 0.4 milligrams. Improvement of liver fibrosis stage with no worsening of MASH, again the dose is the same, 0.4 milligram. Then comes the liraglutide, and this is GLP-1 receptor agonist, All right. Double-blind, randomized, placebo-controlled phase 2 trial in 4 UK medical centers compared liraglutide with placebo in patients with MASH and overweight. And it has shown, as you can see, those two arrows, that this is important. Empagliflozin, I have already said that this is, telling us with the MRI studies that it is benefiting our patients, GLT2 inhibitor. And here comes the muscle MASH management by fibrosis stage. And we know that, look at the top line, which is saying yes, yes, and yes. What is it? It is telling us about the lifestyle intervention, which is the most beneficial for all aspects. Weight loss recommended for overweight or obesity, and pharmacotherapy for MASH. In fact, this is also important when it is exceeding the fibrosis score into that limit, and with cardiovascular risk and diabetes. The TRHRB receptor agonist, we all know that resmetirom, in fact, was made available to us, approved in March 2024 under accelerated approval for MASH with F2 or F3 fibrosis in United States. And there the name is Resdifra. And we are fortunate that now this medicine is available to a variety of drug companies in Pakistan at a very, very nominal price. In US, a single tablet is worth $140. All right? Multiplied by 285 and see a $1 price in US, and this is now there. All right, future of MASH therapeutics, ongoing phases. We know that all this is coming up, and hence we are fortunate in the next few years. It would be a variety of other things, but do not forget the lifestyle modification is mandatory. Everything else fails down otherwise. This is the summary. MAFLD is highly prevalent with variable rates of progression to MASH and advanced hepatic fibrosis. It is crucial to identify those with MASH advanced hepatic fibrosis because it can progress to cirrhosis, liver cancer, liver transplant, and mortality. Patients with type 2 diabetes warrant evaluation. Other risk factors include obesity, metabolic syndrome, first-degree relative with MASH cirrhosis. Pioglitazone and GLP-1 receptor agonists may provide benefits for patients at increased risk of fibrosis. No invasive prognostic biomarkers may facilitate risk stratification. Lifestyle modification and weight loss are the mainstays of treatment. Thank you.
Thank you very much, sir, for such a detailed talk.